IMCAS is an incredible platform for sharing knowledge. It has just a multitude of experts from a very diverse set of backgrounds, from all kinds of cultures and different countries, and I can tell you that there is no other meeting like it.
The best part about IMCAS is bringing together some of the best people in the world when it comes to either aesthetics or even clinical dermatology. This is one of the best places to bring the best minds together to really take aesthetic procedures and bring it to the next generation.
This is one of the biggest conferences all over the world, and I think the attendance of IMCAS is growing year after year.
This is one of the best meetings that I go to.
Dealing with more than 6,000 attendees, 500 speakers, and 84 countries.
Harinatha, I'm a plastic surgeon from India. Yeah, I'm talking about avoiding asymmetry and contour deformities in gynecomastia surgery. Gynecomastia is pretty common in India. A study conducted by the Plastic Surgery Association of India showed an incidence of 40 to 60% of men. This is pretty high, but we don't know the reasons exactly. But the main problem of correcting gynecomastia is the asymmetry. These are some of the patients. You can see most of them have asymmetry to some extent. It's very rare to find a gynecomastia patient who has perfectly symmetric breasts. So when we see a gynecomastia patient, we use this assessment sheet and try to mark out the asymmetries. We especially concentrate on the excess of skin folds, especially which extend to the lateral, the chest wall. We also try to note the changes in the nipple position, along with other factors like the status of the pectoralis major muscle, the skin pinch test, and other things. There are of course different options for treating gynecomastia. Usually we combine a liposuction with excision. Different techniques have been described for liposuction and excision as well. We usually go to the periareolar approach, though different approaches have been tried. We always do it under general anesthesia. We try to use a hypotensive anesthesia. We try to avoid the cauteries as less as possible. And once the markings are done, we try to dissect the gland in a particular way by raising the gland along its superior pedicle. This is how we approach it. Once we do the periareolar incision at the inferior circumference of the areola, then we go in, we dissect in a plane at the superficial fat layer. This is the layer which is in between the dermis and the breast tissue per se. So we first go superiorly, just below the areola, and then superiorly, and then we come down, raise and elevate the gland on top of the pectoralis fascia, and this is where the pedicle is. So the whole gland is raised on top of the pedicle. So this is the idea. So how we start is we make the patient stand, we mark both the sides, we try to mark out the asymmetries. As you can see, this is a grade 2B gynecomastia with significant asymmetry between the both sides. In some people the asymmetry is not as gross like this patient. So first we start with the liposuction. The liposuction also we try to do through the same incision where we are going to make the subsequent incision. So once we do the liposuction, the gland kind of stands out. As you can see, the dotted line that was marked preoperatively. Once we do the liposuction, the gland kind of stands out approximately along that line as well. So this is the right side is where the liposuction has been done, and the gland is kind of more obvious than the left where the liposuction hasn't been done yet. And then this is the first step. We kind of dissect the gland and elevate it superiorly. First we dissect below the areola. Again we try to avoid the cautery. Again it's important to save a little bit of the dermis to avoid devascularization. And again we try to reduce the cautery usage. So once we elevate the gland below the areola, next we elevate it all around. It's a 360-degree job except for the superior part. So we are dissecting through the superficial fat layer just below the dermis. And then this is how the gland it gets elevated. It's attached only at the superior part, it's elevated everywhere else. So I'm holding the gland, I'm kind of dissecting above the pectoralis fascia. So once we finish the dissection, this is how the gland looks. It's attached only at superiorly. And this is the most important step. We assess how much of the breast tissue needs to be left behind. We try to generally remove about 90%. But it again depends on the patient's nature of the body and his habitus and his overall size. We also sometimes check the thickness of the skin.
We're running a bit late, please.
Yeah. We check the thickness of the fat layer, and this is what we try to put back. This can always be customized depending on the asymmetry we're trying to correct. This is immediately after the dressing is removed. There's supposed to be a video here. No. So yeah, generally this is pretty common in India, so we end up operating gynecomastia almost every day. For the last 5 years, we've operated over 1,000 cases. General complications include seromas, delayed wound healing, and minor contour asymmetries. But other than that, there are no major complications as such.